access and anticoagulation in 20 minutes. That's an almost impossible task. So I decided to focus on a few aspects. And for access, I will try to define what the optimal catheter is and where it should be inserted. For anticoagulation, I will discuss why citrate should be the first choice and what are the pitfalls that you absolutely need to know. I first want to stress that a good functioning access is really a conditio sine qua non for adequate renal replacement therapy. So if you don't have a good catheter, you have to replace it, otherwise you will remain with problems. So in acute kidney injury, renal replacement therapy is usually done with a 12 to 16 French double lumen catheter. Catheters in the upper body should be inserted with ultrasound to reduce complications. The optimal configuration has not been really studied, but it's probably this cyclic C configuration that has no sharp angles and therefore will induce less turbulence and clotting. And the same is true for the design of the tip, because the shotgun approach will have less turbulence than a catheter with side holes. The catheter tip should be in high flow location, in other words, in a large vein. But where should it be inserted? We know from the 3 sites study that the optimal location for a central venous catheter in ICU patients is the subclavian vein, because that is associated with a lower risk of bloodstream infection and thrombosis compared with jugular or femoral vein. But the situation may be different for dialysis catheters, because we know that many patients after AKI with dialysis will evolve to chronic dialysis. And then it is important to preserve the vascular network for potential future access. From the chronic dialysis population, we know that subclavian catheters may lead to stenosis, and this will compromise the creation of future access in the ipsilateral arm. So for dialysis catheter, the question is jugular or femoral. And this is a French randomized trial showing that the time to colonization is not different between the femoral and the jugular. So with regard to infection, there's no difference. Only this interesting subgroup analysis showing that in obese patients, the infection risk is higher for the femoral, which is not that surprising. The reverse was seen in the patients with low BMI, which is more difficult to explain. This study also found no difference in catheter-related bloodstream infection or thrombotic complications. And then they did post hoc analysis looking at the risk of dysfunction, and the overall analysis found no difference in dysfunction between the jugular and the femoral catheter. But then they looked separately at the right and the left jugular vein, and they found a clear trend for less dysfunction with the right jugular vein compared with femoral, and significantly more dysfunction with the left jugular vein compared with the femoral. And this is also not surprising, because the left jugular vein has to make several curves before arriving here in the superior vena cava. So this is then the order of preference for inserting the catheter and the optimal length. So the first choice is the right jugular, then the femoral, then the left jugular, and the subclavian at the non-dominant limb is really the last choice, because that's the limb where eventually in the future a permanent access will be created if the patients evolve to chronic dialysis. Sometimes the choice of the insertion site will be influenced by the fact that the patients need to be mobilized, and that will be easier with a catheter in the jugular vein. But you also need to know that if they require high doses of vasopressors, and when the tip of the central venous and dialysis catheter are close to each other, this may cause problems in vasopressor delivery. Okay, let's now go to anticoagulation. Why should we use citrate? It is recommended by the KDIGO guidelines, also by the French guidelines. And the reason is very simple. There are several randomized trials comparing citrate with heparin that are summarized in this meta-analysis of 11 RCTs in about 1,000 patients and 2,000 circuits. And you see citrate reduced a significant reduction of circuit loss that was here defined as a time-dependent variable, and also less filter failure defined as clotting of the filter or a substantial increase in transmembrane pressure. There was also significantly less bleeding, despite the fact that in these trials, patients with high bleeding risk were excluded because they could be randomized to heparin. Of course, there is also less heparin-induced thrombocytopenia if you use citrate. And there was no difference in metabolic alkalosis, which is the most frequent complication of citrate. There was more hypocalcemia with citrate, but no clinically significant problems related to hypocalcemia. So before you start using citrate, it is important to know how it works. So citrate is given here in the arterial line, either as a concentrated solution or as part of the pre-dilution replacement fluid. The citrate binds calcium, and the resulting hypocalcemia results in anticoagulation because calcium is required for almost every step in the coagulation cascade. So part of the calcium citrate complexes are lost in the extracorporeal, in the effluent, and this calcium loss has to be compensated by a calcium infusion, either to the venous line or directly to the patient. The remaining calcium citrate complexes enter the patient, where they are first diluted and then metabolized, and in this process, 1 mole of citrate gives the equivalent of 3 mole of bicarbonate. And it's therefore that the anticoagulation is really limited to the extracorporeal circuit, that citrate is not only an anticoagulant, but also a buffer. And during this metabolization, the calcium that was bound to citrate is liberated, and therefore this results in normal calcemia as long as the extracorporeal losses are compensated. So the treatment settings that you use should reconcile anticoagulation, treatment dose, and metabolic control. And this will require a good protocol, and it's impossible to give you a general protocol because it should be adapted to the local treatment settings, whether you use dialysis, hemofiltration, the type of fluid that you use, but it should take into account electrolyte and buffer balances. You should adapt the buffer content of the replacement fluid because citrate is a buffer, and so on. And this protocol should, of course, be strictly applied, including monitoring of pH, total and ionized calcium, magnesium, and sodium. So what are the pitfalls? There is citrate accumulation and the problem of the management of the calcium infusion. Citrate accumulation occurs when it is insufficiently metabolized and is therefore to be expected in patients with liver failure and with shock, poor tissue and muscle perfusion. The risk is dose-dependent and will be higher if you use a high blood flow or a high citrate target, because this requires more citrate input, or if you use a low effluent flow, because that reduces the citrate elimination. Citrate is not toxic in itself, but it is an unmeasured anion and will result in a high anion gap metabolic acidosis. And the most important problem is that when citrate is not metabolized, the calcium will remain complex and resulting in hypocalcemia. And the best way to detect citrate accumulation is to look at the ratio of the total to ionized calcium. Because in normal circumstances, the ionized calcium is about 50%, so the ratio will be between 1.8 and 2. If the citrate is not metabolized, ionized calcium will decrease and the ratio will increase. And if you compensate this hypocalcemia to normal levels, then the total calcium will increase and the ratio will still be high. So the cutoff was originally 2.1, but in the most recent papers, the 2.5 is used. So this is a small series of 28 patients with decompensated cirrhosis or acute liver failure. They had 43 continuous dialysis runs, and in only 10 measurements in 7 runs had a calcium ratio above 2.5. And they also measured citrate levels. You can see that there is a clear correlation between citrate level and the calcium ratio. So you don't have to measure citrate. The calcium ratio is a good indicator of citrate accumulation. The classical liver function parameters in this small series was not predictive of this high calcium ratio, but the prothrombin and high lactate levels were predictive of this citrate accumulation. This is another larger cohort of more than 1,000 patients, and there are 2 important findings. First of all, in this general ICU population, the incidence of citrate accumulation is low, less than 3%, so it's not that a big problem. And here too, lactate appeared to be a good predictor of citrate accumulation, which is also not surprising because lactate and citrate use the same metabolic pathway in the Krebs cycle. So lactate is a good predictor, but it's especially has a high negative predictive value. The positive predictive value is not that good, so many patients with high lactate will not have citrate accumulation, but it might be an alarm sign to be cautious and maybe monitor the calcium ratio more frequently in patients with high lactate levels. The second issue is the calcium compensation that can be done by an infusion that is managed by the nurses based on a sliding scale, as this one, or it can be integrated in the machine with software-driven compensation based on the settings from the machine, and that will then automatically stop the calcium infusion if the citrate is stopped. It will adapt the calcium dose to changes in the citrate target and or the effluent flow, and it will also take into account the calcium content of post-filter replacement fluid or dialysate. So the problem that you can have with the use of a sliding scale, it's more work for the nurses, there is a risk of error, but it's also unclear what the optimal target should be in critically ill patients, and it may mask underlying problems in calcium metabolism. So many ICU patients, especially in the initial phase of their critical illness, have a spontaneous low ionized calcium level. And it is not clear whether this is adaptive or maladaptive. So should we aim for a normal ionized calcium in the initial phase of critical illness? We don't know. This is a review paper that was recently published in Schetz, and the conclusion was that there are some data that suggest that calcium administration may be harmful in critical illness. As an example, why that it could be harmful is this, what the authors call a natural experiment. Because of the shortage of calcium gluconate, they stopped adding calcium gluconate to the parenteral nutrition, and then they saw that the outcomes improved. And this suggests that the administration of parenteral calcium to critically ill patients that often have hypocalcemia may be harmful. A second problem with the sliding scale is that it may mask underlying problems. This is a patient that was treated for several weeks, and you see a progressive bone loss in this patient. Normally, this patient would have done a hypercalcemia as a result of the immobilization, but this hypercalcemia was masked because the nurses reduced the calcium infusion because the calcium level increased. And then this patient ended with substantial bone loss. So therefore, I think it's really better that you have calcium management done by the machine, where the extracorporeal losses are compensated. This compensation can be set between 0 and 200%, but in our unit, it's always set at 100%. And then we have no or little interference with the spontaneous ionized calcium level, so it will remain low if the patient wants it to be low as an adaptive phenomenon. And we have no masking of underlying disorders of calcium homeostasis. If the patient develops hypercalcemia, we know that that's not due to the treatment, but that there is a problem in the patient and that you have to look for the cause. So in conclusion, the safe use of citrate really requires a good protocol, taking into account all electrolyte and buffer balances, preferably software-driven calcium supplementation. Citrate accumulation is a feared complication, but it is rather infrequent, and lactate appears to be a good, mainly negative predictor. And finally, since citrate also binds magnesium, don't forget the magnesium supplements. I thank you.